It's an incredible privilege to introduce Dr. Hirshberg today. I had to fight Dr. Bizzuto for the honor last night because, as you can see, the three of us were co-residents at Penn, where Adia and I were Laura's chiefs when she was I remember, I say it's particularly interesting to have the interns here because I remember my first interactions with Adia, other than going out for beers after orientation, were when we were opposite each other on the labor floor. And I was working labor floor days as my first shift as an intern, and she was labor floor nights. There is no one better to sign out of the postpartum service to than Dr. Hirshberg. She, as you will see from her presentation, is incredibly compassionate, hardworking. She's a true team player and really cares about her patients. It's no surprise that she is now thriving at Penn as an associate professor in MFM. She's the director of the obstetrical services and the OBQI program there, and has really received national acclaim for her work on postpartum hypertension monitoring. And really, again, the true gift that she gives is her care to her patients. So I'm very excited to see her presentation today.
Thank you everyone for having me. I was saying I hate flying, and so I came here because I love both Lauras. It's been a while since I saw them, and just super happy to be here and honored to be invited. Figured we'd start the talk with some great pictures of a collage of our time in residency and fellowship. Both Laura Cooney and myself stayed on for fellowship at Penn. Laura delivered my first child. I delivered Laura's first child. And you can see there are two best friends right there in one of the pictures. And I think the favorite one here, I don't know if there's a clicker here. I don't know if the mouse works, but that's Dr. Bizzuto sleeping on the first day of intern orientation. A very, very rigorous scavenger hunt. That was great. But anyways, I'm glad that they survived their time at Penn too and appear to be thriving here as well. But again, thanks for having me, and here we go. So the purpose of today's talk is sort of to review the diagnosis of postpartum hypertension and talk about different ways to approach it and manage it, and then speak about different novel approaches for the surveillance and management of postpartum hypertension. I know that you guys have a robust program here, which we'll talk about a little bit as well. So it's really fun to sort of be in a place that has people who are just as passionate about remote monitoring and postpartum hypertension as I am. But do want to mention that one of the things that we'll learn at the end of this talk is there isn't a ton of evidence to support only one way to do a lot of this stuff. And it's definitely an area of research and opportunity, and excited to collaborate with people from this institution, Dr. Hoppy, especially in terms of making progress in the field. So as everyone in this audience knows, pregnancy-related hypertension is hypertension that's induced by the pregnancy. And the most important thing about it is that it's supposed to go away after the pregnancy. And unfortunately for some people, it persists and it doesn't go away as fast as many of us hope it would. The focus on postpartum hypertension really came about in 2013 when the American College of OBGYN had a hypertension and pregnancy task force. This was an interdisciplinary meeting. We did MFMs, we did nephrologists, cardiologists, anesthesiologists, patients, generalists. All these people come together to talk about how to manage hypertension in pregnancy. And after this meeting, they had a lot of the same categories previously for hypertensive disorders of pregnancy. So there was the chronic hypertension, gestational hypertension, the terminology changed from mild and severe preeclampsia to preeclampsia with and without severe features, which includes HELLP syndrome, superimposed preeclampsia. And really, at least for me, as someone who had always been interested in preeclampsia, the first time that they even acknowledged the concept of postpartum hypertension. And so I think this was the first time that people realized that this is something that can occur after delivery and something that needs to be monitored because there are risks in the postpartum period for patients who have persistent postpartum hypertension. And so, a reminder to all the residents and especially the new interns in the room here, that while most preeclampsia will occur antepartum during labor, it can occur for the first time postpartum, and it can persist postpartum, and delayed onset postpartum hypertension is a thing. Delayed onset meaning, 48 hours to 6 weeks postpartum, which is often when most patients are already home after, an uncomplicated delivery. And the incidence of it varies depending where you read. I think historically people would say it was less than 1%. Now that we have so much blood pressure data after delivery from the various programs that we have, I think it's more common than we thought it was. And data from our institution and some of the other literature suggests that about 2% prevalence for new onset de novo postpartum hypertension. And why is this important? Well, people will say preeclampsia complicates 10% of all pregnancies. Where I work, 30–40% of patients have hypertensive disorders of pregnancy, so probably much higher. It contributes to about 20% of maternal deaths in the United States. And it's a leading cause of obstetrical readmissions. About 1/3 of all OB readmissions across the country are related to preeclampsia. And what a pain for patients. They come back to the hospital. Some hospitals have policies that separate the babies from the moms or, aren't allowed to come back in. If you're on magnesium, which we'll talk about later, that also often separates moms from babies. And really a critical time for bonding and recovery, and it's really traumatic for a lot of patients. So anything we can do to sort of be aggressive in management, reduce readmissions for postpartum hypertension, I think is really important for a lot of our reproductive age population. This is an old slide, but I think one of the things that it highlights is how great we have been in treating antenatal hypertensive disorders of pregnancy. So historically, around the country, around the world, hemorrhage, infection, and hypertensive disorders of pregnancy were some of the leading causes of maternal morbidity and mortality, especially, in the United States. And we've gotten so much better at managing those things antenatally that those have come down as far as, the percentage of which they contribute to maternal morbidity and mortality. And things like undiagnosed cardiovascular disease have now taken over and are a major focus in a lot of the cardio-obstetrics world. But I think a lot of this decrease is related to the aggressive and better identification prenatally, and where we still see a lot of death is in the postpartum period. And no talk about preeclampsia can go by without mentioning the disparities that exist in preeclampsia. Black patients are more likely to develop preeclampsia, and they're more likely to die from the disease and increased risk of cardiac arrest and heart failure. And again, there are disparities related to maternal morbidity and mortality related to preeclampsia in the postpartum period as well. This was one of my favorite cartoons. Every time I give a preeclampsia talk, I put it in there. I think it just highlights, all of the different organs that can be affected by preeclampsia. I love, the little baby saying, "I want a belly button," the liver saying, "help," all these great things. But what I don't like about this is everything that I was taught in the past, that delivery is a cure for preeclampsia. Because what I want everyone in this room to sort of realize when we leave is that preeclampsia is a disease that can present itself for the first time after delivery in many different ways. And it's really important to sort of respect the process and not just believe that once a patient is delivered, they are out of the window. Because delivery is not, for me, the cure for preeclampsia, it's just the first treatment. Okay, this is a process that continues after delivery. And so I really, really want to highlight, I hate when people use the word cure because it can persist. People can still get really sick and die after delivery. And this is, I'm a huge sports fan. This is a famous baseball quote, "It ain't over till it's over." This is an editorial out of a cardiology journal. Same thing with postpartum hypertension. It ain't over till it's over. Until someone has normal blood pressures, they're still at risk. So this is from the Preeclampsia Foundation. This is a big campaign that they have. This is a pamphlet that they give to all their patients after delivery. It's called the Still at Risk campaign, to remind patients that you are still at risk after your baby is born. And all patients should go home with some education regarding the risks and symptoms of postpartum preeclampsia. And yes, it's true that the further out you get from delivery, those risks go down, but there are still risks up to 6 weeks after birth. And so educating patients about the risk of seizure, stroke, and the symptoms of severe headaches is super important. So what do we know about postpartum preeclampsia, and how do we get some of the data? So in the 1980s, this is one of the first papers that looked at blood pressures after delivery, and they basically kept people in the hospital for a week after birth. All patients who had preeclampsia. And what they found was that the blood pressure stayed high 1 week after delivery. So from day 1 to day 7, there really was no significant decrease in their blood pressures. In over 50% of the patients, blood pressures were over the 150 over 100 sort of target, range that we sort of worry about as far as starting oral antihypertensives on postpartum day 5. So basically the blood pressures dropped a little bit initially, they creeped up day 4 to 6, and then they sort of maybe stabilized or got a little better, a week out. And many patients have blood pressures in the severe range, 170 over 110. So you can imagine, obviously we're not sending patients home usually with severe range blood pressures, but there are a lot of patients who do go home with blood pressures in an appropriate range, who then once they go home end up having severe hypertension. And if you look at data out of Pittsburgh, they also have a pretty robust remote monitoring program. You can see that patients, will have a more rapid decrease in their blood pressure in like the first 2 weeks. Then you go on to have chronic hypertension with a lot of differences by race, but a lot of people still have pretty significant hypertension in those first 2 weeks after delivery. So this is important because nearly 75% of maternal deaths now associated with preeclampsia occur after delivery. It's a huge number, a huge proportion. Nearly 40% of those occur more than 48 hours after delivery, which again is often after obstetrical discharge. Especially for us, we're always pushed to try to get people out of the hospital sooner and figure out ways to do that. Insurance often, is pushing us to do, postpartum day 1, even, discharges. Patients are asking for that as well, but if patients are still hypertensive, they're still at risk, after they go home. And the highest risk for postpartum stroke is in the first 10 days after hospital discharge. So at least for us, where I am at Penn, we're always trying to figure out ways of, how to get people home and provide patient-centered care, but do it safely with reducing the risk of stroke and severe hypertension after delivery. So if you look at this sort of pathway of blood pressure trajectory after delivery, that first week is the peak blood pressure. That early postpartum period is the highest risk for stroke and maternal mortality. And so how do we keep people safe and monitor them closely in that first week without keeping them in the hospital, 5, 6, 7 days after delivery? So first we have to take a step back and think about why this happens. So sustained postpartum hypertension occurs largely as a result of excess total body water. In some patients, there's suboptimal renal function, especially in patients who've had preeclampsia, impaired sodium excretion, and mostly delayed mobilization of the interstitial and extravascular fluid. And I think that's really important as we think about interventions that can target some of this mobilization of fluid and how to decrease severe hypertension. I put NSAIDs at the bottom because while many people will list this as one of the top 5 causes. I do want to highlight that, so much data has shown that giving NSAIDs after delivery does not cause severe hypertension, and it's much better to continue to give NSAIDs than opiates for pain after delivery, and that we should not be withholding the best pain medication for patients due to concern about severe hypertension in most patients. So I'm big fan of ibuprofen or Toradol. But when we think about postpartum hypertension, regardless of sort of the reasons that someone might have persistent hypertension, we want to break it down into 3 categories. You have the people who had pre-existing hypertension during their delivery admission, so people who we knew had gestational hypertension, preeclampsia, or chronic hypertension. Then you have the bucket of people who delivered without any hypertension during their delivery admission, discharged home with normal blood pressures, and then develop it for the first time, that de novo postpartum preeclampsia. And then there's the secondary causes, the zebras, the pheochromocytomas, and so on, which we're not going to talk about today. But what do we do about this? So we learn that people can be hypertensive. We learn that they're at risk in the first week after delivery. So we called out attention to it. And in the Hypertension and Pregnancy Task Force, and then in a lot of the Optimizing Postpartum Care and 4th trimester documents that came out from ACOG, there was a really strong recommendation to watch blood pressures, get a blood pressure at least 72 hours postpartum, and again at 7 to 10 days after delivery, earlier in patients with symptoms. And it also highlighted that everyone should be discharged with education. So it said, great, everyone gets a blood pressure check at 72 hours, everyone should have a blood pressure check in about a week, but didn't really say how to do this. So they said, for a lot of people, this meant keeping people in the hospital for a long period of time. And again, highlighting that preeclampsia and hypertension are a leading cause of obstetrical readmissions. The goal of, I think, their recommendations was to try to target severe hypertension, reduce morbidity, and potentially reduce readmissions. So what did we do at Penn? We were not going to keep people in the hospital for that long because it seemed unnecessary for a lot of patients. So we created a blood pressure check clinic. This was initially set once a week, every Monday. So whether you delivered on a Monday or if you delivered on Friday, you still came back sort of on that Monday. It was staffed by a resident and an MFM fellow. And we would sit there for a full day and wait for patients to show up to get their blood pressure checked. And it was really frustrating as a resident, and no one would come. I felt like we were just like sitting there waiting and no one would show up. And if you look at our attendance rates over the course of a 3-year period, overall we had 24% Black patients show up and 42.5% non-Black patients show up. And we tried everything. We tried alternate staffing models. We did office hours. We said, you know what, show up whenever you want. You can show up anytime to the office. Someone will check your blood pressure. We called them before their appointments. We texted them before their appointments. And honestly, it just got worse. The harder we tried, it got worse. And so this was clearly not effective. The other thing that we noticed was that people were getting readmitted before this appointment. People were getting readmitted after the appointment because that one-time blood pressure was not sufficient to know where someone was. They could be 140s over 80s at the visit and we wouldn't do anything. The next day they'd be 170s over 100s with a headache. And so the timing of it was important, but this one-time blood pressure doesn't really tell the story of what someone's been doing or what they're going to be doing in that 7 to 10 day period. So we had to think outside the box. And so what we decided to do was create a overall postpartum hypertension bundle. So one of the things we realized in looking at the patients that were readmitted was that we didn't have a standardized inpatient and outpatient postpartum hypertension protocol. There wasn't any consistency in when we were starting medications, what medications we were starting, and when we would titrate medications. And then we needed a remote monitoring texting program. We interviewed patients. They said, I'm not, taking a bus 45 minutes to the office to get my blood pressure checked for 2 minutes to then get sent home. Like that doesn't work for me. Or, I was focused on my baby. I'm recovering from a C-section. Like how am I going to drive all the way down to the office? You told me I can't drive while I'm on my pain meds. So this visit clearly was not the answer. And so we wanted to approach a home-based remote blood pressure monitoring program and develop one. So we'll start with our postpartum hypertension guideline that I want to share here. I know things are done a little bit differently, but every patient with a hypertensive disorder of pregnancy receives a 5-day course of Lasix, regardless of what their blood pressures are after delivery. And they go home with, if they're in the hospital for 2 days, they'll go home with 3 more tablets with potassium supplementation. And then we follow the current ACOG recommendations for a blood pressure threshold of 150 over 100. And we start calcium channel blockers as our first line treatment, either amlodipine 5 or nifedipine 30. We start them while they're on magnesium. Both are acceptable. We have both options because a lot of our patients, even though nifedipine has better breastfeeding ratings, more of our insurance carriers are covering Norvasc 5, but we prefer the calcium channel blockers because they're often once daily medications. It's much easier for the patients to take as opposed to 2 or 3 times, daily labetalol. So we start with the calcium channel blockers. We titrate them every 24 hours initially to get a blood pressure of less than 150 over 100, and then add second agents as needed. So why Lasix? When I started as a resident, it was like forbidden to give Lasix to anybody. We were always taught that preeclampsia is a hemoconcentrated state, volume down, that Lasix could be dangerous for these patients. But more and more data is coming out to suggest that it actually might help control a lot of the volume shifts that are happening after delivery. So for people in the room who don't know, Lasix reduces sodium reabsorption. It's a fast-acting medication. It removes, fluid very quickly. A perfect example is people who have pulmonary edema who get Lasix. They respond really quickly. And in the immediate postpartum period, there are lots of, pretty quick volume shifts that occur due to that sodium and water retention that I mentioned earlier. And these excess fluid volume shifts can result in severe hypertension or unmasked postpartum preeclampsia. And there were some studies out there to suggest, like the largest RCT that was done had shown that if you give Lasix right after delivery and for 5 days, you can lower blood pressures by postpartum day 2, less need for antihypertensive therapy at time of discharge, 6% of patients who receive Lasix compared to 26% of patients who receive placebo. That was an initial study that was done. Smaller studies sort of didn't show any significant effect, and therefore our Cochrane review, at some point during my fellowship suggested that we need more data to decide whether or not this practice should be recommended in order to decrease postnatal antihypertensive therapy. So we did what we always do at Penn. If we want to do something and there's no evidence to support it, we do our own study, and then we just do what our studies show. And so we performed a single-site RCT in patients with hypertensive disorders of pregnancy. We randomized people to receive either 5 days of Lasix or 5 days of a placebo. And we looked at the outcomes of severe hypertension, persistent hypertension at 7 days postpartum, and time to resolution of hypertension. And then we looked at other secondary outcomes, the percent of patients with severe range blood pressures, length of hospital stay, emergency room visits and readmissions. And what we found was a significant reduction in persistent hypertension in patients who received Lasix, 6% compared to those who received placebo, 14%. So by 1 week postpartum, we had a 60% reduction in hypertension. no adverse events. So we looked at things like breastfeeding rates and milk supply because that's often a concern with diuretics, and that there was no difference in that. And so what we found was that the number needed to treat was 13 to prevent one patient from having persistent postpartum hypertension, and faster time to complete recovery of hypertension, 8.5 days versus 10.5 days. Importantly, we had no readmissions, and both findings were noted most actually in patients with non-severe hypertensive disorders of pregnancy, whereas prior studies only showed this data in severe hypertension. But given this finding, this is why we implemented 5 days of Lasix in our population, and we continue to do that today. What about long-term control? So, the Lasix is just for 5 days, and that's to target fluid shifts. I talked about how our go-to medications postpartum are Norvasc or nifedipine, so amlodipine or nifedipine. In our protocol, we offer room for labetalol and hydrochlorothiazide, and a lot of that just crosses over from medications that some patients are already on in pregnancy, but now these are also safe in breastfeeding, and again, we target once daily medication if we can. And I do want to highlight enalapril as an option that is sort of becoming more popular in our population. It is the first-line medication in Europe for postpartum hypertension in that population, and I think people are starting to become more comfortable with it. It is safe in breastfeeding. There's obvious concerns that people will get pregnant while on enalapril, so important to speak to birth control and do contraception counseling, but it is available and safe in breastfeeding and is a very good medicine for patients who have hard to control hypertension. So all that is great. We have medications that are safe. We're trying to target blood pressures, but it remains unclear what the optimal blood pressure goal should be. So ACOG recommends 150 over 100, but is that too sort of low of a threshold, so to speak? Should we be more aggressive? Is it too late? Are we not capturing enough people in the hospital, like not being aggressive enough? And those are the patients who then present a few days later with severe hypertension. Should we move to 140 over 90, which is like the, what we're now targeting prenatally for patients with chronic hypertension coming out of the CHAP study? There is a push to push it even further to 130 over 80, which is the, parameters for chronic hypertension outside of pregnancy. But if we do that in the hospital, or being overly aggressive and not letting the body sort of recover on its own and make those fluid chips out, itself and figure itself out. So is that too aggressive and too soon? And is that more of a target that we should aim for 4 to 6 weeks after delivery? So still a lot up for debate. Again, we're still sort of stuck in this 150 over 100 level at Penn. But with our remote monitoring program, you'll see, I think the more data we have an opportunity to sort of see which patients might need treatment a little bit more aggressively if they're not recovering as fast as we want them to be. So that's medication. So that was our bundle that we created. But what about the 72-hour blood pressure check and 7 to 10 day blood pressure check? Again, our office visits were not the answer. And so we decided to think outside the box, like what would work for our patients. And as a MFM fellow, I found it really, you just look into your waiting room, everyone's on their cell phones. In the ultrasound unit, you're doing an anatomy scan and patients are just like on their phone the entire time. I mean, my kids are just as guilty of like always being on their devices. But this is like what, reproductive age population is using. And so we decided, what if we just ask patients to text us their blood pressures? Like, why come all the way to the office if they could just send us their blood pressure? Obviously, you need a blood pressure cuff to do that. And so that's something that we'll talk about in a little bit. But we decided to look into sending patients home with a blood pressure monitor, ask them to text their blood pressure, and then responding to the blood pressures and what they did. And so we did a little pilot early on using Google Voice, where I sort of acted as a fake back end. And we sent patients home with a blood pressure cuff. We would text them twice a day, ask them to check their blood pressure using the device we gave them. They would manually text their blood pressure back to us or to me. And then I would give automatic feedback on their blood pressure and sort of see what happened over the course of the day. And we compared it to their show rate at the office, which in this population was 15% and probably lower because they were already getting feedback about their blood pressure through text messaging. That clearly was much lower. We had 85% of patients in our pilot text in a blood pressure. So we thought this was a concept that was going to work, but we needed to be able to do this on a lower scale because there was no way that a single person could be texting back and forth with a large volume of patients every day. on its own. And so was the start of Heart Safe Motherhood, which is the name for our remote monitoring program. So basically what it does is give patients blood pressure cuffs in the hospital, text them twice a day to check their blood pressure. And in it is an automated algorithm that provides feedback to patients on a large scale on whether their blood pressure is normal, mildly elevated, or severely elevated. There's an automatic feedback to a covering provider for severe hypertension. And then we have like this whole dashboard of blood pressures that allows us to sort of see trends in patients. Part of this is a lot of patient education. So patients get program-specific pamphlets. They get the blood pressure cuff. The nurses teach them how to check their blood pressure before they leave the hospital using this monitor. They get texted a link to a video that we created that talks about how to check their blood pressure. Also, in case they forgot by the time they went home, there's a short little cardiologist segment here talking about the long-term risks of preeclampsia. We warn them about their symptoms and really targets patients' education in different ways. Some people prefer to read, some people watch videos, and so on. And so we really wanted to make sure every patient understood why it was important for them to check their blood pressure. This is what our program looks like. I don't know if you can see it from where you are, but on the patient end, you can see that they get a good afternoon and good morning message, check your blood pressure. Again, the patient is manually texting in their blood pressure. And then based on our algorithm that we have on the back end, they get automatic messages back. So if a patient texts in, for example, 154/90, it's your blood pressure is okay, keep an eye on it, send another blood pressure with the next reminder. And on the provider end, if someone had, for example, texted in a 166/110, the provider who's carrying the phone for the day will get an alert saying, patient X triggered a medical incident, they had a severe range blood pressure, and that prompts the provider to contact the patient and figure out next steps. And this is sort of the algorithm that we have in place. So less than 140/90, your blood pressure looks great, send it later. Greater than 160/110, your blood pressure is high, they're asked to check it again. But at the same time, the provider is texted that the patient had a high blood pressure, and in between, they're asked to check it again. On the receiving end, you can scroll through all the blood pressures that come through at any given period. This is mostly done as a safety mechanism. If a patient sends in a severe range blood pressure overnight or on the weekends, they're prompted to call labor and delivery. And so for me, this is important. I see this patient sent in a severe range blood pressure at 6:40. I'm going to check in the morning to make sure that they came in or called, and if not, contact them in the morning. But you can sort of scroll through. We ask patients not to write like, I have a really bad headache, that is only for blood pressures, because that's what the algorithm reads. And so if they do send in words, they're told that we only read blood pressures, but you can also catch that here on your review every day. This is the provider view. If you log in every given day, it's color coded, I think very friendly for the provider eye. You can see which patients are in the clear, which patients may need that medication adjustment if they're still in the 140s, or if you increase the medication, it isn't working. And sort of a great just visualization. You can scroll through 20, 30, 40 patients in 2 minutes and see which ones you actually have to call or keep a close eye on, just based on the color coding that we get. And again, this lasts for 10 to 14 days postpartum, with an opportunity to extend for patients who are still elevated after that period. So we actually had to do an RCT, another one, to be able to get buy-in to do this as a standard of care in our hospital, and before we actually put in all the investment into building the program. And we randomized patients with postpartum hypertension to come into the office for that, at that time, standard of care blood pressure check versus enrollment in Heart Safe Motherhood. And we found that enrollment in the program via text messaging, we were able to obtain blood pressure within 10 days in over 90% of patients, compared to only 40% of patients who showed up to the office. We had no readmissions in the texting arm. I truly believe because you have more blood pressure information sooner and can titrate medications more aggressively and more regularly. And we also had an increased postpartum visit attendance rate, 69% versus 58%. And obviously that's really important too, to ensure that patients have good follow-up, especially those with hypertension. We have a cardiology referral program. It's important for contraception counseling, and just generally inter-pregnancy health. So a lot of really good outcomes from this. And we also did a secondary analysis looking at the findings by race. And so in our trial, for patients who were randomized to the office, 70% of non-Black patients attended their blood pressure check, compared to only 30% of Black patients. And with the program, we had over 90% blood pressure ascertainment regardless of race, and we're able to eliminate the disparity that we had. And so this together really gave confidence to our department, our providers, that remote monitoring works. I think this was pre-COVID when people were still scared to do a lot of stuff like this, and allowed the department to support this as standard of care, invest in the program, and invest in blood pressure cuffs that we provide to every single patient at delivery, regardless of where they got their prenatal care. We make sure that patients who are eligible for the program all get a blood pressure cuff so they can participate in the program. It is now the standard of care for all patients with hypertensive disorders at the 5-10 OB hospitals. Since you can see here numbers of implementation, it sort of was a gradual rollout. So HUP was the first site. We started in 2017. We've enrolled at this point, this little data, over 10,000 patients. Pennsylvania Hospital, which is a higher delivery volume, started the following year. And then Princeton, Chester County, and Lancaster, other hospitals. And you can see that no matter where we implement it, nearly 85 to 90% of patients are sending in at least one blood pressure. Many are sending in close to all of the blood pressures, but that's really, really great compared to the office visit attendance rate that we had. And it's been really successful. Our readmission rates have gone down significantly. We are less than a percentage point for patients with known hypertensive disorder pregnancy, largely because of this program. Also because of practice changes that we'll talk about as far as reasons to readmit a patient, but I think that this program has been really helpful in reducing severe hypertension. So, I can't speak about remote monitoring programs without highlighting the program here, and the one at Pittsburgh. The three of us, I think, have really pushed other institutions to develop remote monitoring programs. Some differences that I have here is that our program is automated feedback with what used to be MFM centralization for management of the blood pressures. Used to be an MFM attending, now it's our nurse practitioner, but very much it's not nurse driven on a day-to-day basis. But one of the things that I wanted to highlight is you can see that whether it's HUP, Pittsburgh, here, so many patients need medication initiation or titration after delivery. Here is 50%, at Pittsburgh it's 40%, ours was like 30%. So just highlights the need for ongoing monitoring after delivery and just the decrease in readmissions that's noted everywhere and the high rates of patient satisfaction. Patients love being able to do this from home. And again, this is just similar things that you can see. There was a meta-analysis looking at remote blood pressure monitoring. Our three programs are the ones that are highlighted. And I think just the bottom one talks about the cost effectiveness. Reducing one single postpartum readmission can save significant healthcare dollars. And for us, that's why our health department decided to invest in giving blood pressure cuffs to every patient. Giving a $30 blood pressure cuff, over the course of the year to each patient and reducing, 2, 3, 4 readmissions is cost effective in and of itself. Not to mention the cost savings of getting patients out of the hospital sooner, knowing that you're going to get a blood pressure the next day. So we have this program, which is great, but like I said, I'm running out of time. How do we get 100% engagement? So it's great to get 85%, 90%, but there are some patients who don't send in any blood pressures. There are some patients who send very few, and I think that's like an important part of all of these programs. Like, how do we capture everybody? So we actually broke down our initial years of patients into non-users, minimal users, moderate users, and super users based on how many blood pressures they would send. So non-users never sent in a single blood pressure. Super users sent in more than 75% of the requested blood pressure. And what I want to highlight here, I think is just super important from like a postpartum perspective. Every single patient thought that checking their blood pressure was a low priority. I'm not sure like how good that is given how much education and focus we have on it. But what made people check their blood pressure was the ease of the postpartum transition. So the super users reported a somewhat easy postpartum transition, whereas the non-users said they had a really difficult postpartum transition. And I think it just speaks to like why providing all this patient-centered care, doing it from home, doing whatever it takes to sort of ease their transition is helpful in addressing not just blood pressure issues, but postpartum depression, breastfeeding support, all that stuff. Like making it easier for our new parents to manage any part of their health is the key to, I think, improving postpartum care and morbidity and mortality in the United States. And this was just like one way that we got to some of those, realizations. So if you think about self-measured blood pressure monitoring programs, I mentioned before there are some differences in different programs. Do you monitor only high-risk patients or do you monitor all patients? Do patients get monitored by their own individual practice or is there a centralized hospital model? Who's receiving the blood pressures, a nurse or a physician? Is it a generalist or an MFM? Is it cardiology or nephrology? There are many places where cardiology or nephrologists are I don't know why it's doing something, are managing the blood pressure medications after delivery. When do you do this? Is it just a postpartum program, or is there benefit of doing antenatal, remote blood pressure monitoring, which we recently started? And how frequently should you be checking blood pressures? Is daily too much? Is twice daily too much? Should we be just checking weekly? These are still things that are unknown, but different ways that you can do a program. How do you get the blood pressure information? There are places that use automated, Bluetooth monitors. We chose text messaging because our patients just don't have great access to wireless or Bluetooth technology, and the actual texting of the blood pressure is not a barrier. And it's really simple technology. Oftentimes people think that technology can increase disparities in care, but simplifying things, making it text message based, not needing, a smartphone, just needing text messaging, I think was key to our success. But regardless of how people do this, I think we know that it's important. It reduces outpatient visits. We have closer surveillance and it's convenient. High patient satisfaction, reduces readmissions, shorter length of stay, and most importantly, reduction in maternal morbidity and racial disparities. Other advantages, it's easy to use and low cost. It empowers patients. And I think importantly, we've gotten so much data on blood pressure trends after delivery, which is super important for research. But there are limitations. There's not many validated cuffs in pregnancy, and who knows if immediately postpartum, those cuff validations are the same as for pregnancy. A lot of questions about the accuracy of readings when patients check their blood pressure themselves. Again, lack of guidance for the optimal frequency and timing of the request for the blood pressure, and it relies on a really big infrastructure. You need support on the receiving end. That's been the biggest barrier to implementing programs like this across the country. Who is going to be managing all of these blood pressures that are coming in? Who is going to be comfortable managing all the blood pressures that are coming in? Because in a lot of places, you start a program like this, and initially people have information and more people get readmitted because now they're seeing more severe range blood pressures. And so you need to find people who are comfortable sort of aggressively titrating severe hypertension as an outpatient, not sending every single patient into the hospital. And obviously cost. Reimbursement, in every state is different. We've been working very hard with our payers to try to get reimbursed for some of our programs, and there is increasing support for telemedicine and telemonitoring, but still a major issue. One thing that helped us work with a payer and get some more reimbursement is we actually partnered with IBC, which is one of the bigger payers in Philadelphia, and we needed to get more long-term data too. So we had previously shown that our program works in the short term and reduces readmissions and severe hypertension in the short term, but what about long-term outcomes? And so we were able to partner with them and use claims data to look at post-discharge outcomes up to 6 months after delivery, comparing a asynchronous cohort as well as a synchronous cohort. So we looked at patients who delivered at our hospital before we implemented Heart-Safe Motherhood, who would have been eligible for the program, but we just didn't have it. And we found that patients in the program had less composite adverse outcomes of stroke, eclampsia, pulmonary edema, cardiomyopathy up to 6 months after delivery. And we also looked at patients in the time period who delivered during Heart-Safe Motherhood, who delivered at hospitals without the program, but would have been eligible in those hospitals, and also found similar benefits, decrease in a composite adverse outcome up to 6 months post-discharge. One of the great things that we found was that our postpartum hypertension bundle also includes a referral process to primary care and cardiology. And using claims data, we were able to show that more patients enrolled in the program followed up with a cardiologist or a subspecialist in the 6 months after delivery, which is the intent of our program, and less patients went to the emergency room or had inpatient readmissions for hypertensive issues. So all the things that we want. Follow up with a PCP, cardiologist, or a specialist for your hypertension, decrease emergency room visits and readmissions for hypertension, and that's up to 6 months after delivery. So even more cost saving, not just in the short term, but long term. So our program is specific for patients who have a known hypertensive disorder at time of discharge. But what about delayed onset postpartum hypertension? So a lot of the different reasons that we mentioned before are the same for delayed onset postpartum hypertension. Volume overload, they do mention NSAIDs here, although I mentioned how I feel about that. People who just weren't diagnosed previously with hypertension and all these other less common things. Patients who are at risk for delayed onset postpartum hypertension have a lot of the same risk factors: obesity, age, non-Hispanic Black race. Data from our institution shows that patients who have C-sections, especially after like long failed inductions, or who have more net positive fluid status at time of delivery, so longer length of labor, or who had a postpartum hemorrhage, are more likely to develop delayed onset postpartum hypertension. Most of these patients are presenting postpartum day 7. The literature suggests that many of them have symptoms, but overall the rate for readmission is low. And so there's questions of whether this is a different disease or whether it's just a subset of patients who just didn't yet declare themselves during the pregnancy. And there are people trying to look into the pathophysiology. This is a study that came out looking at biomarkers, angiogenic biomarkers, and they found that both patients who had pregnancy preeclampsia and then postpartum preeclampsia all had the same sort of biomarker findings. And so there's a thought that while it may be a little bit different, these patients are just showing it later for some unclear reasons, and definitely sort of an area of study. One of the things that I wanted to mention is that we also have a low-risk blood pressure monitoring program for patients who don't have hypertension at time of delivery, with the goal of catching de novo postpartum hypertension, but it's less intense, less frequent. So these patients only get 8 reminders to check their blood pressure over, a 6-week period, as opposed to twice a day for 14 days, which is a lot. And we found that about 3% of our patients will develop new onset hypertensive disorders of pregnancy after discharge. Those are often the ones that are getting readmitted. About 40% of them are diagnosed based on blood pressure alone without symptoms, and just over a half of them are diagnosed following symptom reports. So you can still have asymptomatic severe hypertension, which if a patient isn't aware of preeclampsia and not aware what their blood pressure is, can be at risk for stroke. So now what? We know that you can develop hypertension after delivery. What do we do about it? We monitor it, we get the information, you find out a patient has severe hypertension, what do you do? I think it's really important to figure out how you're going to manage your postpartum patients. For us, location of postpartum emergency care is super important because we were finding that patients were being discharged from the emergency room with untreated new onset preeclampsia. So for us, all postpartum patients within 2 weeks of delivery come to OB triage, no matter what the issue is, as long as they're hemodynamic, not in in major cardiac extremis. From 2 to 6 weeks, anyone with hypertension comes back to our OB triage, and then there's other OB-specific complaints that do that. But we found that really helpful in order for us to be able to aggressively manage hypertension to the targets that we think are important and reduce the risk of stroke. So not the 200s over 100s that the emergency room is comfortable with, but even the 150s and recognized preeclampsia. We have a BPA and an icon that pops up in any patient who shows up to an outpatient visit or the ED, suggesting that the patient is newly postpartum. That's up until 6 months after delivery. So that's not just for hypertension. I think that's important for all cardiac issues, shortness of breath complaints that come postpartum, to reduce sort of missed evaluations for cardiac disease and pregnancy. And some of our delivering hospitals use these preeclampsia foundation bracelets. Just highlights that you recently delivered, that you're at risk of preeclampsia. You wear it until you're sort of out of the window. Not many patients actually wear it, but they do exist for this reason. So different ways you can highlight it, but I do think it's really important for OB to be very involved in the management of their own patients after delivery. And for this reason, we also tell patients to show up to we try to urge our patients that if they have a problem after delivery, to return to the hospital in which we deliver, to ensure that they're getting an OB managing their blood pressure. What do you do when they do show up to the hospital? I think this is, one of the things that is different in a lot of places, but we sort of break it down into whether they have hypertension only or hypertension and symptoms. With hypertension only, we're just aggressively treating their blood pressure to a place in which it's okay for them to go home. And then if they have symptoms, we consider imaging or magnesium to reduce the risk of stroke or seizure. And similar approach for patients with new onset hypertension as well. And these are all different algorithms that you can find in AJOG, a lot of data in the past 5 years about different approaches to postpartum hypertension. So as far as acute treatment, it's following the same algorithms that you would antenatally, hydralazine, immediately release nifedipine or labetalol, and then the age-old question, to MAG or not to MAG after delivery. I just took some quotes from different papers that have highlighted this in the past few years. The first one says, no conclusion can be drawn about magnesium. Is it that it's not as well established as antepartum preeclampsia management? There's not enough RCTs to think about whether or not magnesium sulfate is needed postpartum. A paper came out saying, suggesting that they reserve magnesium sulfate for the subset of patients with neurologic symptoms who are at the highest risk of eclamptic seizures. and remaining research questions from this review. If so, like how long after delivery does one get magnesium? You know, if someone presents 6 weeks postpartum with severe hypertension, are we magging them? I think more people are comfortable saying no these days, but there are still places that do that. And so at least for me, what I like to share, you know, if someone has neurologic symptoms, I have a lower threshold to give them magnesium, but I do take into consideration, you know, did they get magnesium before during their delivery admission? Do they have symptoms? How far out are they from delivery? Do they have like lab abnormalities? Not everyone is getting blood work, you know, and we feel very comfortable not sending everyone in, you know, in hardship motherhood for labs. I really just tend to use it for people who are symptomatic and closer to delivery. So that's sort of my spiel. I think my understanding here, it's getting a little bit more similar to that as far as not needing to mag all the patients who return. And I think that's a big factor as why we've been able to reduce readmission rates. Most patients were being readmitted purely for magnesium, and we have found that the magnesium is presenting the risk of seizure, not necessarily stroke. And so if we can just target aggressive treatment of hypertension, we might be able to reduce a lot of the morbidity in patients who don't have symptoms, who without symptoms are therefore less likely to be at risk for, you know, a seizure. So we, again, follow this for hypertension only. We start them on blood pressure medication, and if they respond, we send them home with continued outpatient surveillance. And if they do have neuro symptoms, consider magnesium sulfate or imaging. And this is pretty consistent. If patients have headaches or blurry vision, consider magnesium. And again, these are the blood pressure parameters in which we currently are recommended to start blood pressure medication, although I still think we could probably be more aggressive. So that's 1 week after delivery. I think I have, what, 10 more minutes, maybe? Sorry. Okay. The average time to normalize blood pressure is about 6 weeks postpartum. So even though we're pretty aggressive in the first week, some people may still be hypertensive up until 6 weeks postpartum. And in 80% of patients, blood pressure will normalize by 12 weeks. It might take a little longer. So 20% of patients go on to develop chronic hypertension. Our own institutional data suggests that patients who are more likely to develop chronic hypertension, are obese, had more severe preeclampsia and preterm preeclampsia, or were discharged home on an oral antihypertensive medication. So I do counsel patients about the importance of follow-up, and this is why we have a referral process. You can see here, again, this is the data out of Pittsburgh that suggested that a large proportion of patients still go on to have chronic hypertension after delivery, more common and more frequent in Black patients compared to white patients as far as chronic hypertension at 6 weeks postpartum. Important for our patients to know that pregnancy is a window into future health, and many studies have demonstrated an association between preeclampsia and future cardiovascular disease. This is like the favorite cover to a non-OB journal. This is from Cardiology, and it basically talks about gestational disorders being a risk factor for cardiovascular disease, not just preeclampsia, but preterm delivery, gestational diabetes, you know, other adverse pregnancy outcomes. And it's just really nice to see other specialties embracing sort of obstetric health and reproductive health as far as it relates to their fields. So women with preeclampsia are at higher risk of future cardiovascular disease and stroke, 4 times more likely to develop heart failure, 2 times more likely to have cardiovascular death or stroke, even higher risk if you had severe preterm preeclampsia. So patients who have preterm preeclampsia who deliver before 34 weeks are 10 times more likely to die from cardiovascular disease than patients who had healthy pregnancies. So again, important part of counseling for patients with preterm preeclampsia. And the question is sort of why. I think a lot of people believe that patients who have preeclampsia, especially those discharged on blood pressure medications, go on to have, you know, vascular disease, left ventricular dysfunction, other cardiomyopathies, and the adverse pregnancy outcomes do that and then push you into overt cardiovascular disease. So it's just sort of unmasking people who were already at risk for developing cardiovascular disease. And if you think about risk factors for developing preeclampsia and you break them down into the OB risk factors and then the maternal risk factors, many of the maternal risk factors are the same as for patients who, you know, aren't pregnant, you know, for cardiovascular disease. So again, is this just like a second hit hypothesis? And now we're like just unmasking people who were going to develop it, you know, at some point in their life, but now sooner and more severe. So much that history of preeclampsia or pregnancy-induced hypertension is a risk factor as far as cardiovascular disease risk stratification, need for statins later in life. Really important that patients know their OB history, know to tell their doctor that they have preeclampsia or an adverse pregnancy outcome just as much as if they smoke or have metabolic syndrome or are obese. So important for them to understand the associations so that it can be included in the calculator and make sure that they're getting the right treatment, whether it be a statin, aspirin, and so This is our referral process that we have to cardiology. It's a little hard to read here, but basically we try to make the referral when the patient is still in the hospital so that they have an appointment. So patients who have term preeclampsia, who are discharged home on blood pressure medications, anyone who had preterm preeclampsia, regardless of whether they're on medications, or chronic hypertension with superimposed preeclampsia, is supposed to get a cardiology referral. Everyone else is supposed to get a primary care doctor referral. And again, we try to make sure patients have these appointments before they leave, because it takes 3 to 6 months to get those appointments, and we want to make sure that they have timely follow-up. This is important because every patient with preeclampsia, especially severe or preterm preeclampsia, should have a blood pressure check, a cholesterol check, an A1C, sometime 3 to 6 months postpartum when the lipids sort of normalize again, and just sort of have that done serially to make sure that they're getting appropriate treatment to reduce the risk of cardiovascular disease later on in life. Another plug for telemedicine. We had this cardiology referral program for patients with preeclampsia. We have a great relationship with women's health cardiologists. You can see that the show rates for their office visits in 2019 was 43%. COVID came along, we moved a lot of those visits to telemedicine. And so from January till June of 2020, we only had telemedicine visits. And then after July, patients could opt for in-person visits if they wanted. And you can see that the completion rates for counseling about long-term risks of preeclampsia increased significantly with the use of telemedicine. So again, the postpartum population, even not just 1 week out, but 6 months out, this is super helpful in terms of getting them the counseling that they needed, plugging them into long-term care. This is just a visit. I don't know how many patients completed their blood work and did all the other things, but at least they're getting some of the counseling about what it is for them long-term. And then lastly, this is like what I like. I think it's like a really nice pregnancy history form that was in one of the internal medicine journals. You can fill out all the paperwork when you go to a doctor's visit. This is a pregnancy history form that really is trying to highlight, how many pregnancies do you have? Did you breastfeed? Did you have a premature birth? Did you have preeclampsia? How many? Did you have growth restricted babies? All these things to highlight any sort of adverse pregnancy outcome history as it relates to long-term health. And in conclusion, postpartum hypertension and preeclampsia is understudied, but carries a high risk of maternal morbidity. A lot of our management is extrapolated from antepartum recommendations, and we just need to do a lot more research specifically on the postpartum population. Telehealth is effective in the postpartum period, and future research should focus on blood pressure trends, biomarkers, which blood pressure medications are most effective, who should get magnesium postpartum, and more research on future cardiovascular risk. That's a picture of my kids from a long time ago. It was Valentine's Day, but I like to say that it is for heart disease and preeclampsia. So that's it. I'll take any questions. I'm sorry, I know I talk really fast. The New York.
Any questions? I don't know if we have anything online.
That's good.
Okay.
Thank you, Dr. Hirshberg. I was wondering, with how we see the cardiovascular risk increase when you have hypertensive disorders of pregnancy, with being able to aggressively treat it with your programs and what we do here too, do you see those risk factors going down over time? Like, would you see that 4 times more likely to have heart failure reduced because you're managing it better now versus before when we had these telemedicine?
I think it's hard to know. I mean, that's the hope, that, if we can get people on the right medications and they have better controlled, hypertension for longer periods of time, that all of the downstream effects as it relates to, arterial stiffness and, cardiac dysfunction will decrease. And then yes, that down the road that is. And maybe just maybe more awareness of your health is part of it also, I believe. And so getting plugged into care and doing all those things and getting preventative health, stuff like that, lifestyle modifications might be a part of it too. So, it's hard to know how much of it is a treatment, how much of it is the knowledge and the empowerment of the patient. But that's the ultimate goal, is to decrease the risk later on in life.
Maybe we should do a long-term follow-up study of these patients. Thank you.
Thank you so much for that excellent talk. I'm Alison, I'm one of the generalist faculty in the department. I have more of a global health focus. And I have a couple questions for you. One was in creating the remote blood pressure monitoring program. like what sort of collaborators were you able to work with to like create the texting app and algorithm, and who helps with maintenance of that? And in terms of the blood pressure cuffs and resources that you need to support the program, are patients returning for blood pressure cuffs? Do they get to keep them? And how do you maintain kind of your resources to support the program?
All great questions. So the platform was created through a pen-based, it's like a HIPAA compliant platform that initially was intended to look at like cardiovascular disease and lifestyle interventions through like a gaming and like constant intervention, but it has that automated function. And so we just took a spin on it and to create, you know, the blood pressure aspect and the automated feedback for blood pressures. So it's like a separate pen-based program that we were fortunate enough to team up with through a grant that supports that aspect. And so they have innovation designers and builders that help to put in sort of to create the platform on the back end, but now they're sort of only involved if there's technological glitches, but the program is pretty smooth now. And now that we have an algorithm, any other institution that wants to sort of buy into it can just readapt the algorithm into their, you know, model of the EMR and so on. Or you can, you know, even change your parameters for however you want for your institution or direct patients to different prenatal practices and so on. So there's ways within the system to more personalize it to any institution's need. The blood pressure cuffs are just given to the patients. They are not returned. There was a lot of concern about cleaning them, the cost of cleaning them and things like that. I will say that since COVID, a lot of our patients get blood pressure cuffs prenatally. We do a lot of telemedicine prenatally and the insurances are covering it in the state of Pennsylvania. And so the patients use those blood pressure cuffs postpartum. And so we only need to supply a handful of cuffs for patients who don't get their prenatal care with us. So that cost has gone down as well. But that's part of the departmental budget and they continue to just give us an ongoing supply of cuffs for patients that need them. But we do try to get the patients the blood pressure cuffs through insurance ahead of time.
Thank you so much for coming. It was really great to have you here. My question is about research and involving like departments, and you spend a lot of time on labor and delivery and work with residents. Like, how do we empower and encourage, you know, be like, at Penn, we do a trial to answer this question, and we don't just like make changes because we read a paper, but that we actually like put some framework or something to it, and like, how do you fund those as well? So just to really get people in the room excited about hypothetical research.
Yeah, well, we have like a pretty robust like center for reproduction research, and we just, I mean, like this program started through a grant. So, you know, I applied the first like 3-4 years of the blood pressure cuff costs and the program and the infrastructure to run the RCT was all based on grants. And I, you know, as a resident, I didn't really know about a lot of these opportunities. It sort of was more during fellowship, but there are so many different like institutional grants, smaller grants. The AHA is interested in, like, if you just like look out there, there are so many different ways to get small amounts of money, which go a long way. And then the program success, we've applied for different, you know, prizes through, you know, the government, you know, or the even innovation competitions looking at health outcomes and, you know, winning $40,000 here, 100, like all that stuff goes and then like resupplies the program and sustains it. So I think that's part of your question too. How do you sustain it? So even though the program is sort of self-run now, all those things that we did in the beginning by learning about these different opportunities help pay for where it is now. But I think we're very lucky. Yeah, you know, I feel like where I work, we also make it fun. You know, who can consent the most patients for a research study? I think Laura and I for like an induction study, like who can consent the most patients gets a gift card to like a dinner or whatever. And but I think the more it's sort of a cycle, right? So like, you know, we did this induction study and it was published and then now it's standard of care and people realize how cool it is that a lot of the country does stuff based on like what we did. And now we have a new research study. And so that's exciting for residents to think that maybe they're going to be part of a research study that's going to change the way we practice later on. And so I do think it's a cycle. And the key is to get patients to consent to it and figuring out a way to do that. But I think it's really exciting to change how we practice medicine and to be a part of it. And, you know, even though you don't do OB anymore, I'm sure you can remember.
We did all the PPCOs for like PCOS and letrozole, metformin, Penn was part of that, which is pretty cool.
But if you're curious, you can fine with me.
Oh yeah, we have an online question from Dr. Gaston. Do you think we should be targeting the ACC-AHA goal less than 130/80 postpartum?
I don't know that I would push it. I think 140/90 for me would be like a better target, at least initially in the first like 2 to 3 weeks. I think by 6 weeks, it should be 130/80. But I think initially, I don't know that it's necessary to be super aggressive. You know, I will say we don't find that many patients become super hypotensive, so we're not dealing with patients who are going to the 90s over 50s and symptomatic after delivery. So like, I don't think it's like a super aggressive target, but I just don't know that it's necessary yet in the immediate like first 2 weeks, and let the fluid chips figure themselves out and see where a patient settles out. I think if someone is still hovering in the high 130s or 140s at 6 weeks postpartum, you know, I definitely think that that's a target that we should reach at that point. But I do think like there is something to say for letting things figure themselves out a little bit without, you know, aggressive treatment in the first week or two.
Awesome, thank you so much.